Dr. Sandlow is on the board of the Institute of Medicine of Chicago. He is an emeritus professor of medicine at the University of Illinois at Chicago, and he's on the board of the Portis Foundation. Portis Foundation is the sponsor for this upcoming session on immunizations in the time of COVID-19. Dr. Sandlow, you there?
I'm here.
Wonderful.
Good morning. Welcome to this conference, which so far has been really fascinating, and I'm sure the rest of the day will be. The session is immunization strategy and COVID-19. What do we know? You already know who I am. I just want to mention that Portis Foundation is sponsoring this to a great extent because it fits exactly into our mission, which is in the support of research, innovation, and education in health promotion and disease prevention. And what fits better than immunization? It's my pleasure to introduce the outstanding panel that you see in front of you now. Cheryl Rucker-Whitaker.
Just say Cheryl. Just say Cheryl. Hey, let's skip. Everyone knows me. Skip mine. You're good.
Anyway, she's already introduced. She's the CEO of NextLevel Health and the president at this time of the Institute of Medicine of Chicago. She's a physician, healthcare executive, and entrepreneur. And in 2014, she co-founded the NextLevel Health, a groundbreaking insurance company, which is really dedicated to helping Cook County underserved access and manage the whole issue of Medicaid services. In 2020, this current year, she was recognized by Cranes as one of the notable women executives. The next of our panel includes Helene Gayle, the president and CEO of the Chicago Community Trust. She's a pediatrician as well as a public health physician who spent really 20 years or more of her life with the Centers for Disease Control, working on HIV/AIDS and disease prevention. She also led the Bill and Melinda Gates Foundation program on HIV/AIDS and some other global health issues. And then for the past decade, almost, she's been the president and CEO of CARE.
So it looks like Les may have disappeared. So I'm gonna just jump in. Dr. Gayle, I think we got you introduced Samantha Olds-Frey. So Sam, I don't have the text in front of me, but what I'm gonna say what I know about you. Sam is the Chief Executive Officer of the Illinois Association of Medicaid Health Plans, which represents all of the health plans currently serving the Illinois Medicaid managed care market. Thank you so much, Sam, for joining us today. And then Donna Thompson. Donna is a registered nurse by training, and she's the CEO of Access Community Health Network, our state's largest federally qualified health center, and was really on the front lines when the state asked FQHCs to join in with supporting the testing rollout. But they take care of hundreds of thousands of people across our state as an FQHC, and will be on the front lines of any vaccine distribution. So thank you all for joining. And we're gonna jump right in. Dr. Gayle, you're gonna walk us through, you co-chaired the work group for the National Academy of Medicine on equitable distribution of the COVID-19 vaccine. So you're gonna take us through those recommendations. We know you have to leave shortly, but walk us through, stay as long as you can. And we look forward to having you update us on that report.
Great. Thanks so much, Cheryl. And I'm sorry that I won't be able to be here for most of this, but it's hard for me to say no to Cheryl. And so I carved out a few minutes to be able to do this. I think we had some slides. So as Cheryl mentioned, this was a study that was done with the National Academies of Science, Engineering, and Medicine, along with the Academy of Medicine. As people, I'm sure here know, the Academy of Medicine is what the Institute of Medicine used to be, and now it is merged within the National Academies of Engineering and Science as well. And we can go to the next slide. You know, these studies that are done by the national academies generally have a study sponsor, oftentimes a government agency, and our study sponsors were CDC and the National Institutes of Health. And I think they asked for this study to be a fast track study, given how fast the development of vaccines were going. And I think they also did it with the hope that the independence of the national academies would be helpful at a time where there's been so much confusion, lack of transparency initially, et cetera, around the vaccine development. And so we were asked to do this study on at the request of these two agencies. The next slide. Study committee, I was very fortunate to have as my co-chair, the Bill Fagey, former CDC director, also one of the co-leads of the effort to eradicate smallpox globally, a real public health legend. As you can see, we had a committee, a broad-based committee, about 18 people, bioethicists, statisticians, public health physicians, epidemiologists, immunologists, gerontologists, et cetera. You know, a really rich group of people to pull this study together. We had about 2.5 months. Anybody who's been involved in some of these studies know that they are usually a year to 18 months. So this was a really fast track study with a lot of information to take into consideration and pull together. Next. The overarching charge was to develop an overarching framework for vaccine allocation to assist policymakers in the domestic as well as global communities about what does it take to have an equitable allocation of the COVID-19 vaccine, with the hope that this will inform decision makers and national health authorities, including the ACIP. And the ACIP, Advisory Committee on Immunization Practices, is CDC's standing body that recommends on the distribution and implementation of vaccine programs. So it was envisioned that this would be an overarching framework that others could then take and develop further. Next slide. We had to take into consideration some of the specific aspects of this pandemic and of this particular virus and its evolution. So, one of the things that we felt was very important to take into consideration was the disproportionate impact on racial and ethnic groups. We did this by looking at some of the increased risk in communities that were really linked to social and structural inequality. So disproportionate representation in high risk jobs, disproportionate comorbidities that lead to serious outcomes if somebody is infected with SARS-CoV-2, et cetera. So really wanted to look at what were some of the increased risk factors. And then obviously we know that advanced age along with comorbidities are other important aspects to this pandemic. So those were some of the things that, were highlights of this particular pandemic that we thought was important to take into consideration as we looked at our framework. And as we looked at in the next slide, kind of some of our overarching issues. This just gives the vaccine landscape. As everybody knows, there's a lot of candidates out there. Many of them are still in the preclinical development stages. And there's now over 38, but close to 40 being tested in clinical trials. We know here in the United States, so that's the global picture. In the United States, we have U.S. Operation Warp Speed that has a portfolio of 6 candidates, and 4 of those now in phase 3 trials. Importantly, we know that these phase 3 trials too will have a new platform, the mRNA platform, Others are using things that have been used before, replication defective vector vaccines. So we have both a new vaccine being developed, but also a new platform and vector, and one that has particular requirements, and that I think will play into some of the aspects around the distribution. You know, we went into this both without an actual vaccine, as well as a lot of unknowns that would affect the allocation of vaccines. So, you know, in some of the vaccines, they are 2-dose vaccines. So where others will be developed, it will probably be 1 dose. So we, you know, the timing and the number of vaccines and even the availability of vaccine doses, we don't know how many will be available by when. We still don't know what the efficacy is. You know, while there is clearly more and more safety data being collected, you know, there's, because of the speed and the time that the vaccines are being developed, we won't have the safety profiles that we often do when we start allocating vaccines. Vaccine uptake, you know, there's been a lot written, there's been a lot talked about around people's hesitancy around taking this vaccine because of the speed of the development, because of some of the politicization of the vaccine, et cetera. So we, you know, there's a lot of concern and a lot of unknown about vaccine uptake, even once it's available, the number of available vaccines. With so many vaccines being developed at one time, we don't know how many will actually be out and ready and circulating at any given point in time, et cetera. What are the epidemiologic conditions? Will we be in an upswing? Will we be in a stable state? Will we be in a declining state of transmission? So many unknowns were part of this, and we tried to do scenarios to think about what would be, how would it impact our vaccine allocation given some of these unknowns and uncertainties. So pulling all of that together, I'll get to our framework. And, you know, at the bottom there, we wanted to have some important foundational principles because we wanted to make sure that this was grounded in both ethical principles as well as procedural principles. And the ones that we thought fit this particular pandemic the most, as far as the ethical principles, were: 1, maximum benefit. You know, how could we make sure that this allocation had the most benefit for the most people? Equal concern, all lives being equal and not judging whether one profession or one circumstance was more important than the other, and that the mitigation of health inequities was critically important, particularly given the disproportionate impact on communities of color, and certain procedural principles that we followed in our allocation. Fairness, transparency, and transparency being a big one, again, because of some of the concerns about vaccine hesitancy, and then evidence-based, making sure that we were leading with the science and not with politics or others. So we came up with this allocation framework with the goal of reducing severe morbidity and mortality and negative societal impact due to the transmission of SARS-CoV-2. And we used a risk framework for our allocation criteria. So the risk of either acquiring and by extension also transmitting infection, the risk of severe morbidity and mortality. And again, as we know, there's been such huge societal impact. We also thought the risk of negative societal impact by somebody getting the virus or getting the mortality or morbidity was important as well, and came up with the 4 allocation phases in the next slide. So, and I won't go through these in total detail, but just to kind of give you the general thinking, with those risk criteria: acquisition, severe morbidity, mortality, negative consequence, and risk of transmission, we looked at this in terms of how those applied to different populations. And we used phases as opposed to tiers. Oftentimes you'll see vaccine allocation frameworks have tiers, which are more static and often say that there's groups that should have it kind of consistently more than other groups, oftentimes with age cutoffs. Here we felt that once a vaccine was available and once there was enough vaccine, everyone should have access to the vaccine, but we know at the beginning there's going to be scarcity. Therefore, we had to look at who should get it first and then, kind of roll out after that. Not surprisingly, in the very first phase, we have high risk health workers, both because they're at high risk of acquiring, potentially of transmitting, and because of the impact on society if healthcare workers are not available. We also said the same for first responders, and we didn't put like EMTs, et cetera. In our healthcare workers, we didn't say physicians first. We said anybody, and this is really based on who was at most risk because of most contact. This would include nursing home, health home care workers, et cetera. Anybody who was at high risk of contact and who also would have a negative societal impact if they were not able to take care of people with illness. We have then looked at, and we put a jump start because, again, we know that there may be very, very limited amount of vaccine in the very beginning, and because the candidates that are further up the line are ones that may not be able to be distributed through the normal kind of decentralized way in which vaccines are available, and that they may need to be done in a more centralized way, particularly for the vaccines that require very, very stringent temperature controls. Also in that first phase, we had people of any age who had one of the very most severe comorbidities that put you at the highest risk of severe disease or dying, and then older people living in congregate or overcrowded settings. We then kind of went down that risk allocation framework that we had. And, as an example, in phase 2, we have teachers, K through 12, critical workers in other high-risk settings, people living in congregate settings like homeless shelters, prisons, jails, detention settings, and then all older adults, 65 or so older and older. Third phase, young adults, children, with the caveat that children have not been part of the first phase of clinical trials, so we'll need to make sure we have the right clinical trials data to be able to see whether or not children should be part of that phase. Hopefully by then we'll have enough information about children, and then workers in industries that are important but don't have some of the key societal impacts as in the first 1 or 2 phases. And then we say in phase 4 that everyone residing in the United States, regardless of legal status, so anyone living in the United States should have access to the vaccine. Because equity was such an important part of our consideration, we had as a cross-cutting issue that in each of these phases, vaccines should be prioritized for geographic areas identified with CDC's social vulnerability scale or some other specific index that looked at the social determinants of health and the risk factors that put communities, and particularly communities of color, at highest risk. You can skip 2 slides forward. Next. So just quickly, summary of our recommendations. First and foremost, we recommend that this framework be adopted and that policymakers take into consideration this framework as a basis for allocation, that we leverage and expand the use of existing systems. There's been a lot of discussion about having alternative ways of distributing and allocating the vaccine. We know that there is a strong tradition of national vaccine programs with CDC leading and providing guidance to state, territorial, local, and health authorities. We feel that's the system that should be built on, and not creating parallel systems just because this is a different situation, that we will be much more well served if we use the channels that have worked well. We thought that cost considerations were incredibly important. Billions of dollars have gone into making this vaccine, such that cost should not be a barrier, and that nobody should have to bear out-of-pocket costs, not only for the vaccine, which people have already pledged to provide free, but also for the administration of the vaccine. The next three really relate to this issue of vaccine hesitancy. And we really felt it was important to have multiple recommendations. First, one around developing programs on risk communication, so people actually understand the risks and the benefits in a transparent way, that there be community engagement as part of this, so that communities are hearing this from institutions and organizations that they trust, that there be at a national level a vaccine promotion campaign. So again, that people are hearing this in a consistent fashion, and that in the process that we develop an evidence base for what the most effective strategies are for promotion and acceptance of this vaccine. And then finally, we made a recommendation about global allocation. We were asked to do so as part of our charge, but we also felt a real obligation that at a time when we have been withdrawing from the global collaboration around vaccine, at a time when we're saying we should back away from the World Health Organization and not be a part of COVAX, which is the global COVID vaccine facility, that this is the time to affirm our commitment to the global world and to be part of this global effort, because it's the right thing to do. We've always had a leadership role as a global, as the United States in global health, but it also is the right thing, the smart thing to do. We are not an island, and if we're not engaged in the global world, we can't expect that we're going to keep our citizens safe while we're not engaging globally and making sure that everybody is safe and that we all are looking at this in a collaborative way. So I will just stop there. I think I've just about taken time. I don't know if you want to take one or two questions, or we turn it over to the panel.
Dr. Gayle, right now we don't have any questions in the chat. So okay. I want to thank you for helping to set the stage here. You followed up on Dr. Ezike's kind of comments around Illinois, helped us with the national framework that's being proposed. So really appreciate you coming. We're gonna ask Samantha and Donna to come up now, and we're gonna kind of walk through a series of questions.
Thank you.
Really about our ground level strategy. So thank you so much, Dr. Gayle. So thank you so much. I think Samantha and Donna, I see you. Hold on one second here.
Good morning.
Hey there. Yeah, so we learned a bit from scheduling this program, guys, that we needed a webinar program and not a Zoom call program. So I don't have you both on the same page. So I apologize for that. But what we do have on the presenter screen is a picture of all of us, right? So folks don't get whiplash from flipping back and forth to find us. So Sam, I see you. Donna, I see you. Thank you guys so.
Cheryl, you're on mute. Oh.
Okay. Wow. Okay. Someone wants me to stop talking. So Donna, you were here from the beginning. You heard Dr. Ezike talk a little bit about the current immunization challenge, given the last 7 months and the events associated with that. You heard about the upcoming COVID-19 vaccine, and unless you live in a bubble, you can't help but hear all the kind of the politicization, if you will, of this vaccine, and nothing quite like, I mean, you've been in healthcare, quite some time here, nothing probably like you've heard in your lifetime. So if you put all that together with the work you do every day, so I'm asking you kind of a loaded question because I want you to just start out. Why don't you just kind of opine on your thoughts from what you've heard, but what you see every day. I heard when you guys rolled out your testing site, there you go again on the front lines of bringing testing to a vulnerable community. So clearly you understand the communities that, when Helene was talking about kind of zip coding and taking a look at this COVID sort of vulnerability index that meant something to you. Why don't you kind of give some opening remarks there around your kind of thoughts in response to kind of what you've heard so far and, you know, informed by your work to this point?
Absolutely. Well, thanks so much, Dr. Gayle, for your remarks, and also Dr. Whitaker. Access is in 16 of the 20 most under-resourced communities in the Chicagoland area. And when we thought about how we would set up COVID, you know, a lot of the learnings, as we've said, as we've gone along, and how we, you know, every week we're learning something different. But early on, it was important for us to think through not just about COVID testing, how to get our patients or people engaged in their health because of the disparities, but also we knew that if it would go into the long winter months, how could we keep the momentum going? And so we set up 5 COVID sites at Melrose Park, Auburn Gresham, Inglewood, New City, Cicero, and Little Village. They are either right next to, we had some raw space right next to a health center, or we even took 2 health centers and converted them into COVID testing sites with the thought that, again, if there is a vaccine, we could quickly pivot and do mass vaccinations. Now, that's all well and good, but one of the things that we knew early on is that we had to have community engagement, and Dr. Gayle talked about that, and also Dr. Ezike. Before we even started, per each community, and again, we've got a long history of working with our various community partners, really engaging them, and here's our thoughts. What are your thoughts about how we could best engage, get the word out? Still a lot of fear, a lot of hesitancy about testing, but again, got a lot of what I call sage advice on the best approaches to testing. You know, historically, and unfortunately, especially in our communities, flu vaccines is still something that patients don't readily take. And so when you think about a COVID vaccine, I think Dr. Gayle was right. You know, there's a lot of perceptions, whether it's, you know, the politicization of it, to how fast it could get to the market, to even, you know, what it could do to me, because people even heard some of the early studies. And I think right now it's going to be key to pull those groups together, to start having a dialogue, but not just with the community, even with our own healthcare workers. This afternoon, we're going to be having some forums and continuous forums, not just on inside access and for all of our employees, not just on issues around race and health equity, but also their perceptions about the vaccine. You know, it's not uncommon for someone to come into our health center and their most trusted person is that front desk person who's been sitting there for 20 years, or that medical assistant, or even in some places, a security guard. And so we really have to make sure that we understand their beliefs, where they're at, and they can really be the ambassadors. You know, one nod which way can really impact a patient on whether they take the vaccine or not.
Donna, are you there?
Yes, I'm still here.
Okay.
And so one of the things that part of our lessons learned, not only around community involvement, but also as we even partner with some of our MCOs. Currently, they're able to go into our electronic health record and schedule patients who are high risk, some of those high risk members, also working with our care coordinators. It's also important as we think about technology to really use that as an extender. And, you know, when Dr. Ezike talked about, you know, the upcoming holidays, you know, we're looking at how do we do a campaign, not only for our workforce, but also with the community at large around family and friends and the necessary steps that they'll need to take in order to keep themselves and their loved ones and the community healthy.
Great. No, that sounds like you guys have a lot of experience in this regard. So having you at the table is going to be critically important. Samantha, are you there?
I am. Can you hear me all right?
Yes, ma'am. Good morning. Samantha, the IMHIP, as we affectionately call it, you represent Medicaid payers across the state who represent many of our most vulnerable citizens. And for those of you who don't know, the state's Medicaid program covers about 3 million of the 12.5 or so million Illinois residents. So 25% of people are currently using some part or all of the Medicaid benefit. What are the Medicaid health plans seeing on the ground with regards to vaccination rates currently, Sam? And how are you all thinking about, and how are we thinking about improving those trends?
Yeah, so thank you, Dr. Whitaker, for having me and for posing this very important question and dialogue, because what we're seeing, so to put the 3 million members in context, so it's about 25% of the population, but we are covering actually over 1/3 of the children in the state. And then obviously we're also the largest payer for long-term care. So we've been particularly, our members have been impacted by COVID and then by vaccination rates. And what we've really seen in 2020 is not surprising, as everyone has said, a decrease in vaccination rates. In Illinois, we've seen the trends nationally, especially for younger children under 24 months, we're seeing very alarming rates. We are starting to see, which is sort of my small piece of hope, is that the first half of the year, so we track everything using our HEDIS measures, we saw significant drops. I mean, just truly jaw-dropping drops the first half of the year before July. We are starting to see trends return to normal or closer to normal, which is promising, but we're not necessarily seeing sort of a woodwork effect. We're just seeing a normal vaccination rate, which then means we're not picking up all those children, who weren't vaccinated earlier in the first part of the year. We think that part of our increase in vaccination rates comes through a lot of the efforts that the providers, that the plans, and that we're collectively doing to encourage flu vaccinations. So people are going, families are taking their children to get flu vaccinations, and then they're hopefully also catching up on some of those other vaccinations that were missed earlier in the year. But we are still seeing significant decreases in just our standard vaccinations. And to really, I think, tie on to something that keeps myself and our clinical folks up at night is the conversation and the politicization of the COVID vaccine really ties into conversations that we were already having and already worried about vaccine hesitancy across the board. And so it's sort of furthered that conversation and that concern. And so vaccine hesitancy was already a significant public health concern for all of us. And now we're almost seeing it sort of we're doubling down on battling vaccine hesitancy, having really frank conversations, empowering our clinicians and our provider networks on evidence-based conversations around vaccine hesitancy, because we are going to, for probably the next 12 months or longer, really have to have frank and scientifically led conversations around vaccines, not only for COVID, but for for a multitude of diseases.
What are in the light of COVID-19 and kind of everything that you've talked about, what is IMHIP anticipating with regards to vaccine policy over the next 12 months? Are there any sort of changes that we need or changes that you see coming? I know you heard about the report that Helene spoke of, and the governor's rolled out this, they're also thinking about the equitable distribution and getting to most needed communities fast. But are there any kind of policy changes or policy coming down the pipe that you anticipate or that you think we need to have in place?
So I think there are a few that we need to have, and there are some I anticipate. So I think depending, much like Helene spoke about, Dr. Gayle, I think that depending on whatever vaccine is approved, there may need to be policies in place and structures to provide effective and efficient vaccinations that may or may not utilize sort of our standard, you go to your pediatrician or your PCP for vaccinations. It may be more different events, and there'll be a lot of work from a public policy perspective that I fully anticipate that. What I think that we need to do from a policy perspective on sort of our traditional vaccines is change how information is shared from the Department of Public Health, specifically with Medicaid and Medicaid health plans. So today, pediatricians and physicians have access to eye care, the vaccine database, as does the plans, but really only one individual from the plan, typically our CMO, has access to eye cares. And we don't receive a flat file or any sort of large, sort of information about our entire membership. We receive member by member information. And why that's a concern from a vaccine perspective, especially when we're thinking about children vaccinations and the flu vaccine, is you don't necessarily get full gaps of care information that you can then share with your provider networks, because the health plan is only receiving information on vaccinations if they're billed for a vaccine. But as we talk about potentially, and we would strongly support access for vaccines where there's not a claim coming into a health plan, then the health plan is blind to whether or not that vaccine, whether or not that member got vaccinated, which means we can't then communicate with the member or our provider network about who's been vaccinated, who hasn't, where are the strategies, where are spots that have been under vaccinated, or where are sort of the areas of most need if we don't see that information. And so I think that's something we need to start doing now from a public policy perspective, get that live feed of data that is not individual by individual, but rather membership, so we can break that down, share those gaps of care with our member or with our provider networks, so we can collectively engage our members. I think it's important that we start doing that for our traditional vaccines and flu vaccines, so we can work out those processes, right? Like, it's technology, we're dealing with state files and HFS and then the plan. So starting now so that we can then do that work when a COVID vaccine comes through, I think will be critical. Or else the plans are flying blind and we can't serve as that additional resource or extender from the public health entities.
So Samantha, what you're saying is you want that data feed basically gives you with a population view. That way you can implement population health practices and you can more efficiently target your efforts. And so I think that's be a piece of critical feedback we can give to the director. We told her we'd send her some critical feedback. So I'm going to need that just appropriately worded from you so we can get that as part of our recommendations. So guys, we have to wrap up here, which this is awesome. Donna, we got a question about the use of community health workers in supporting either kind of buy-in, if you will, from a trusted source role, and also just facilitating people getting to vaccines or knowing where they are and knowing where to go. Do you have any thoughts on the use of community health workers in the front line of COVID vaccine acceptance and distribution?
Absolutely. I think that that's a very viable strategy. The one thing, though, I would say we need to broaden who we think could have that impact. To me, let's bring in our faith leaders. People like, hairstylists, barbers, people who are well respected in the communities. We really need to get to them also to start the conversation. And so as community health workers, I think that that's one strategy, or tactic, but I think, again, we need to really broaden our net and really look at also those trusted community groups who have been long-term and have had a legacy of having great impact with and being trusted by those that they relate to in their own community.
And Donna, what you say, we've done these kind of campaigns before, right? Remember we talked a year and a half ago, we were talking about breast cancer awareness, and we had a crew of folks together who were involved in getting breast cancer screening rates up for Black women. Absolutely. And all women, remember? I mean, Absolutely. We've done, yeah.
Well, I've got my pink on today, Cheryl, because it is breast cancer awareness. And I think one of the things I agree with Samantha and Dr. ZK, we still need to continue, especially with this long legacy of healthcare disparities, and really working to get people and to stay engaged and get their preventive screenings. And at the same time, you know, we just had an event with the AKAs of Evanston, not only getting the word out about breast cancer, but also talking about issues like COVID. So again, I think every touch point that we have with community partners, we need to have it as a teaching moment, but more a listening moment.
And we had a question in the chat that, you know, when are we going to start pushing out the campaign to help people kind of depoliticize the vaccine and kind of right size the message? I don't know if we all have an answer for that. I mean, I think there has to be funding, guys, right? Like we've got to have the dollars to do that, right? Like no dollars have showed up yet for that. And so I hope that doesn't make us get too far behind, if you will. Samantha, any closing remarks from you before we?
Yeah, I just want to thank you, I think, for this conversation. I did see a question regarding, you know, around vaccine hesitancy and those evidence-based conversations. We did a three-part at IMHIP. We did a three-part series on vaccines, engaging over 200 providers, advocates, leaders. Those are all recorded on our website, and I will send one of the specific one on vaccine hesitancy over to you, Dr. Whitaker, to share with the questioner. But we are. I just want to thank you for this conversation. I think Donna's absolutely right. Really listening, engaging the community, using unique resources. You know, we're partnering with CPS on vaccination, education, and other public health components. So, you know, going beyond sort of what we think of traditional healthcare to have a broader dialogue.
Donna, any closing remarks?
Yes, I think as we move ahead, one of the things I'm most proud about in Chicago is how we've linked arms. And, you know, from a state to local, where we're really bringing in the best ideas, we're learning from each other. And I think, again, that's really a hallmark of what we need to do as we go on this unprecedented journey together.